Karthikeyan, holding a postgraduate degree in general medicine. I am here to share my clinical knowledge in a crisp and conceptual manner. Yeah, today we are about to see SLE. What's SLE? SLE is usually a multi-system inflammatory connective tissue disease. This is usually an autoimmune disease where the antibodies are directed against double-stranded DNA. These antibodies are usually non-organ-specific antibodies, so this affects almost entire parts of the human body. Yeah. Who are getting affected? If we take SLE cases, 9 among 10 patients are usually women in the reproductive age group. This is because this disease is usually estrogen driven and estrogen dependent. So women in the reproductive age group are usually getting affected. Males can also get SLE, but this is rare. But when it happens, this is usually a serious one. Yeah. How come someone gets SLE? This someone is a genetically predisposed individual. Someone with a early complement deficiency like C1q or C2 deficiency or TREX gene mutation. This genetically predisposed individual, if he or she gets an environmental trigger, this is usually a viral infection. So someone with a genetically predisposed condition gets an environmental trigger, he or she may get the first episode of SLE. Yeah. Coming to the pathophysiology. This is if I have to tell the pathophysiology of SLE, this is usually a type 3 hypersensitivity reaction. In the sense, it's an immune complex mediated reaction. Yeah, usually when the antibodies react to the antigen, this forms an immune complex and this gets phagocytosed easily. But what happens is here, the apoptotic bodies are not cleared off by the immune system. It gets deposited in the blood vessels of entire parts of the body. Okay. This is subsequently attacked by the neutrophils and complement proteins. So this damages the endothelium and eventually compromising the blood supply of the organ where the immune complex gets deposited. If this happens in the blood vessels, the patient may develop vasculitis. If this happens in the kidneys, the patient may get renal glomerulonephritis. This happens in the joints, he or she may get the arthritis kind of features. Yeah. Coming to the clinical features, SLE has umpty number of clinical features. So one has to know the umpty number of presentations to diagnose SLE. Yeah, the common things in which SLE can present is the patient may present with mucocutaneous involvement or musculoskeletal involvement or constitutional symptoms. These are the common things. In the mucocutaneous involvement, the patient may get the malar rash. This is typically a butterfly-shaped rash, which is a non-scarring, which spares the nasolabial fold. The patient may also get arthritis kind of features. Constitutional symptoms like fever, fatigue, weight loss can also be a feature. The patient also can present with renal manifestations like glomerulonephritis, CNS manifestations like depression, cognitive impairment, hematological manifestations like anemia, thrombocytopenia. These are the common presentations of SLE. So what we are bothered about is the complications that a patient with SLE may develop. So if the cardiac coronary blood vessels get affected, the coronary blood supply is compromised and he or she may develop myocardial infarction in the long run. So the cardiac complication is the long-term complication which we anticipate and we are not expect to happen in a patient we are treating. Yeah. So coming to the lab investigations. ANA is the gold standard diagnostic thing for SLE. When we suspect SLE, we have to do ANA. So ANA is positive in almost 97% of the cases. That means if someone is negative for ANA, we can almost rule out SLE. Yeah. Other tests include we can do ESR, CRP. We can also do C3, C4 levels when we suspect lupus nephritis, and we can also do urinalysis to rule out proteinuria if we suspect lupus nephritis. Specifically coming to the ANA profile, anti-dsDNA, this is the, almost positive in more than 70% of cases. Anti-Smith antibodies are positive in maximum cases, and this is specific for SLE. Other antibodies like anti-histone antibodies are present in drug-induced lupus, anti-ribosomal P antibodies are present in CNS lupus. So these are the investigations we are about to do. So this ANA is only for the diagnostic part. For the follow-up part, we usually prefer how the clinically the patient improves, but in the investigation part we can use ESR and anti-dsDNA for follow-up cases. Yeah, coming to the management. Pharmacological management comes secondary for me, myself. for myself, non-pharmacological management comes primary. Yeah, we have to provide the patient sun protection films and sunscreens. Yeah, this is because UV rays are a big trigger for the SLE flare-ups. So we have to put the patient on sun protected films, and we have to reduce the risk for cardiovascular disease. So we can improve the lifestyle of the patient, we can treat obesity, we can instruct him to stop smoking. In this way, we have to prevent the patient for cardiovascular disease. So coming to the pharmacological management, if someone is diagnosed with the SLE, we have to start the patient on steroids. Steroids are the first line of management, obviously. If we consider the disease as a low risk kind of mild disease, we have to start the patient on 1 milligram per kg per day steroids. And if we consider the SLE first episode as a serious life-threatening issue, we can put the patient on pulse methylprednisolone, following which we can taper the steroids and put the patient on disease-modifying anti-rheumatoid drugs like hydroxychloroquine, azathioprine, methotrexate. We can switch over the patient from steroids to DMARDs. So other than DMARDs and steroids, we can also use NSAIDs for the arthralgia. In resistant cases, we can do plasma exchange, and biologicals like rituximab can also be used. So, what is the prognosis of SLE? SLE prognosis is almost improving day by day, and today at present, almost 90% survival rate is there for a 10-year survival rate. Yeah. What are the complications and causes of mortality in SLE cases is, in early SLE cases, the mortality is due to the disease per se, and also due to the immunosuppressants we are using, and the secondary infections the patient may get. So these are the early causes of mortality in SLE cases. In the later stages, the patient may die of cardiovascular mortality. So this is how SLE is. Thank you.